No, I'm Dr. Rishi. I'm representing North Alabama Medical Center. I'm going to present you an interesting case of Bean syndrome, which is Willow-Rivers syndrome. Next, next slide. BRBNS or Bean syndrome introduced to us by William Bennett Bean uh, in 1958. This BRBNS syndrome, also known as Bean syndrome, is a rare congenital vascular malformation which is characterized by the appearance of the blue compressible venous malformations in the skin, GIT, and less often other visceral organs. It's an autosomal dominant condition. Its locus is located on the chromosome 9 short arm. Next, please. Diagnosis is most commonly clinical with the pathognomic cutaneous lesions, and we can see these lesions also on endoscopy of the GIT, and histological presentation of these is dilated capillary structures lined by thin layer of epidermis with bluish intestinal nodules with the normal mucosal walls. Gastrointestinal tract, particularly the small bowel and colon, which present with acute and chronic bleeding. In our case, which was extremely rare, that the cutaneous lesions were not present in the patient, and in that also, this patient was only having the GI lesions present, which is in a retrospective analysis of 120 cases of BRBNS cases, reported manifestations of disease without skin condition in only 7% of cases, which is extremely rare in this sort of rare condition. We present one of the cases of BRBNS involving esophagus and colon without cutaneous manifestations. Physicians should recognize that BRBNS can represent without skin involvement and have complications from the visceral organ involvement also. Next, please. Our case is an interesting one because we had an adult onset BRBNS, which is also a rare presentation. An 88-year-old man presented to our facility with generalized weakness, near syncopal episodes, and episode of fall, and secondary to lightheadedness. He had 2 to 3 episodes of dark bloody stools preceding the event. On presentation, he was hypotensive with a blood pressure of 77 to 34 millimeter of mercury, hemoglobin of 5.3, PTINR of 42.7 to 4.6, and stool occult was positive. Stool occult blood was positive. Past medical history, coronary artery disease on atorvastatin and clopidogrel was there, and he was on having atrial fibrillation and was put on warfarin also. Heart blocks post status post pacemaker, congestive heart failure, hypertension, and diabetes. With family history, no family history was present in this patient. So for workup, we did EGD in the revealed medium-sized bulbs in the upper third of the esophagus. The rest of the esophagus, stomach, and duodenum were normal. The colonoscopy showed 2 non-bleeding angiectasias in the ileum, which was likely the source of bleeding. A mucosal nodule was noted in the rectosigmoid colon, consistent with the blue nevus syndrome, which was biopsied and showed diminutive hyperplastic change. Next, please. Management. He was admitted. This patient was admitted to into ICU and for hemorrhagic shock and GI bleed and supratherapeutic INR. He received 2 units of FFP, 4 units of PRBC with resultant hemodynamic. He was started on intravenous pentaborosol and stabilization of the hemoglobin was done. And thereafter, coumarin was resumed and titrated to the targeted INR. The patient was followed up in the gastroenterology clinic closely and serial hemoglobin remained stable. Discussion. In BRBNS might present at birth in 30% of the patients, in infancy in 9% of patients, and mostly, sorry, in early childhood, 50% of the cases. One of the persistent complications of BRBNS is iron deficiency anemia due to chronic bleeding from the GI tract, requiring iron supplementations and frequent blood transfusions. Our patient describes a unique scenario of adolescent BRBNS limited to the GI tract, serves to highlight the importance of a high index of clinical suspicion of BRBNS, even when the presentation is atypical without the cutaneous lesions. And the age group is also not the childhood, but it was an adult onset BRBNS. Physicians should recognize that the BRBNs can present without skin manifestations and may have complications of visceral organ involvement also. Next, please. For treatment, multiple therapeutic modalities are used in the management, including the anti-angiogenic agents like interferon alpha, octreotide, sirolimus, sclerotherapy, aggressive surgery also can be used. For endoscopic interventions, these patients can go to get band ligation, laser ablation, sclerotherapy, glue injection, surgical excision, and photocoagulation for control of GI bleeding. Next. Here I'm showing a picture of an endoscopy of the patient, where you can see the Bean syndrome, the nevus there. This vascular ectasia looks like a nevus. So you can see. And next, please. Even if my patient was not having the cutaneous lesions, but for educational purposes, I put up this slide to show that most importantly and most commonly these patients present with these cutaneous lesions, and then we suspect after that they might have the visceral organ lesions also if they are having some anemic symptoms, lightheadedness or bleeding, FOBT positive, they come to us with lightheadedness or something like that. So this, but in my case, the case was adult onset and without any cutaneous manifestations. So high index of suspicion is needed if you have a patient with a blood loss and not have any cutaneous lesions. So you can keep BRBNS in your DD for those patients also. Thank you so much.
Thank you very much. That was a very helpful review. Does anyone have any questions regarding the previous presentation?
Hi, I just wanted to say that I found this presentation really helpful. I know it's a really rare condition. I've also heard of it because we had a patient in Arkansas that we treated for this, but it was a child, 14-year-old, who was also presenting in kind of a shock-like presentation and had this in her GI tract as well. So really interesting and small world. So just thank you.
Yeah. Thank you so much. Yeah, that was my point, that we can, even the most of the patients present in their childhood, and it is a most so clinical suspicion is more in the childhood cases. Adult onset cases are very rare and without the cutaneous manifestations. So wanted to keep this point up and emphasize more on this, that we have to keep this syndrome in our mind while making the DDs for upper GI bleeds. And even though warfarin was in the supratherapeutic range for this patient, and patient was on coumarin and antiplatelet therapy, so still we have to keep the suspicion there. Thank you.
Okay, well, thank you very much. And if there aren't any questions from the audience over in Pigeon Forge, then we can move on to our next presentation.
Thank you so much.
Yeah, absolutely.